Bismillah ar-Rahman ar-Rahim. I'm Amer Aleem. I'm a hematologist at King Khalid University Hospital, Riyadh, and I will be hosting this webinar today. I welcome you all on behalf of Saudi Society for Blood Disorders and the Saudi Society for Blood Disorder Hematology webinar series. We have three eminent speakers today. Our topic today is immune-related thrombocytopenia in 2020, and we will cover different aspects of the ITP during this webinar. And we have 1.5 hours time. I will show the program now. I hope you can see it on the screen. After the opening remarks, we will have the first talk by Dr. Mansoor Al-Jabri. And then we have a second talk by Dr. Hazza Al-Zahrani. And then we have third talk by Dr. Hani Al-Samkari. And I will give a detailed biography of our speakers as we go along with their talk. So now I have the pleasure to introduce our first speaker. Dr. Mansoor Al-Jabri is an associate professor and consultant hematopathologist at King Khalid University Hospital, College of Medicine, King Saud University. He is also chairman of the pathology department at the same institution. His main interest in research and is clinical and research aspects of thrombosis, hemostasis, as well as hemoglobinopathies. And he's going to talk about, can we go back? No, go back. Sorry, there is some, yeah. So he's going to talk about pathophysiology and diagnostic challenges in ITP. So Dr. Mansoor, please go ahead. I will stop sharing the screen and you can show your slides.
Thank you very much, Prof. Amer. Assalamu alaikum, Masa al-khair alaikum jami'an. Good night for you all. And it's my pleasure to be with you today to talk about some aspects in pathophysiology and some diagnostic challenges of autoimmune thrombocytopenic purpura. I will talk about autoimmune thrombocytopenic purpura for the next 20 minutes. Okay, yes, now it's moving. So as introduction, autoimmune ITP is an acquired immune destructive thrombocytopenia characterized by isolated thrombocytopenia. And this disease is mainly caused by antiplatelet autoantibody. So we can differentiate this from alloimmune thrombocytopenia like post-transfusion purpura or fetal-maternal alloimmune thrombocytopenia. And the mechanism and the pathophysiology is not only because of autoantibody, but also because it's of decreased production and as well as cytotoxic T cell destruction. As the role of cytotoxic T cell destruction is expanding, and we now start exploring this role. And as autoimmune disease, it has female predominance. And ITP, as all of you know, manifested as bleeding tendency, like epistaxis, erythrosis, or petechiae. When it comes to classification of ITP, there are two classification schemes for ITP. According to the clinical outcome of the disease, it's been classified to acute with newly diagnosed patient less than 3 months, or persistent if the disease persists for 3 to 12 months. If the disease exceeds 1 month, 1 year, I mean, it is refractory. If the disease has bleeding, if the patient has bleeding manifestation that require treatment, this is severe. Actually, this is a clinical outcome, and I am pathologist, so I'm interested in this classification, which is etiological-based classification. Etiological-based classification classify the ITP to primary or secondary. And primary ITP here, we don't have any other associated disorder. And diagnosis usually is of exclusion. That means we have to exclude all other secondary causes like H. pylori, like hepatitis C, hepatitis B. And the issue here is that we don't have any pathognomonic clinical or lab feature. And the best diagnostic parameter here is the response to therapy. So if the patient responds to IVIG or steroid, it will confirm our diagnosis. While in secondary, It includes all other immune-mediated thrombocytopenia, and it might result from infection associated like hepatitis B, hepatitis C, HIV, and it might result from autoimmune disorder like SLE or Evans syndrome, in which we have ITB and autoimmune hemolytic anemia at the same time. Lymphoproliferative disorder is commonly present with autoimmune, with ITB like CLL, sometimes drug-induced causes. I will focus mainly on primary ITB. So when it comes to the prevalence of primary versus secondary ITB, primary is the predominant type of ITB, which represent about 80%, while secondary represent about 20% of ITB, in which the SLE and antiphospholipid syndrome is the most common type of secondary ITB. Now, pathophysiology of ITB is a very complex pathophysiology, and ITB as a result of complex immune dysregulation, in which actually the initial spark of that immune complex starts from B cells and plasma cells, which produce autoantibody that opsonize the platelets, and opsonized platelet will be destroyed by macrophages. But this is not the initial, again, this is net result of suppression of T regulatory, which is subset of peripheral T cells, represent about 5 to 10% of peripheral T cells. And they have inhibitory mechanism, and they have suppression mechanism of autoimmune mediated mechanism. And again, the imbalance between T helper 1 and T helper 2 also leads to activation of cytotoxic T cells, which again have a crucial role of activation of macrophages and apoptosis of megakaryocytes, and also impaired of thrombopoietin production, as you know. The antibody produced or autoantibody produced is mainly against platelet glycoprotein, surface glycoprotein 2B3A, and also glycoprotein 1B95. And in some cases, in some acute cases actually, it might be against also thrombopoietin receptor. The opsonized platelet destroyed in the spleen through the spleen macrophages through FC or cycloreceptor. But again, in acute cases, actually it's been documented that acute ITB patients, they have also complement-mediated lysis. So direct platelet lysis through the complement has been documented in some severe cases of IT. The other arm of pathophysiology of ITB results from megakaryocytes itself, actually. And now if you see the bone marrow in ITB, you will see that there are many megakaryocytes, and you assume that they are producing enough number of platelets. But in fact, they have actually increased, ultrastructural study proof that they have increase of para-apoptotic activity, like dilatation of demarcation membrane. And demarcation membrane, actually, demarcation membrane system play a major role in builds off and release of platelet from megakaryocytes. So any deficiency, any mutation that affects that system, it will lead to abnormality of releasing of platelet from megakaryocytes. For example, Wiskott-Aldrich, which is microthrombocytopenia, as a result because of a mutation that leads to acceleration of the enzymes and gene in that area. And microthrombocytopenia, Bernard-Soulier disease, also caused by delay of those enzymes. So in ultrastructural study proof that patients with ITB have para-apoptotic activity. More than that, also impaired thrombopoietin production. Thrombopoietin is the major growth factor that is responsible about maturation, differentiation, and specialization of megakaryocytes, as well as platelet. So thrombopoietin again as impaired. This is the structure of platelet, as you can see. And the glycoprotein 2B3A is the most abundant glycoprotein in the platelet structure. And it plays a crucial role in platelet-platelet interaction because it will interact with fibrinogen, and the majority of the autoantibody are against this glycoprotein. The other glycoprotein, which is usually commonly targeted with autoantibody, is the von Willebrand glycoprotein receptor, which is glycoprotein 1B59. Now, thrombopoietin, as I said before, is the growth factor that is responsible about maturation and differentiation and also release of platelets from megakaryocytes. And many studies actually proved that thrombopoietin, the increment of thrombopoietin thrombopoietin in ITB is not sufficient to maintain normal platelet count. And if you see this study, which compare between normal patients, which have normal platelet count, and aplastic anemia patient, which have low platelet, and also ITB patients, the increment actually of thrombopoietin in aplastic anemia patient is 10-fold increase of the normal, while it is almost normal in ITB patient, which became the essential, the rationale behind using of thrombopoietin mimickers, as you know, like rhodoplastin and electron. This is one of the most interesting experiment which has been done in 1951, and Harrington was taken by the experiment that has been done by Combs when he discovered that Combs test is positive in autoimmune hemolytic anemia, and it became the essential investigation to prove that we are dealing with autoimmune hemolytic anemia. So he did this, and actually he sacrificed with himself, and he injected himself with about ½ liter of ITB patient plasma, just to confirm his hypothesis about the presence of humoral antiplatelet, that the ITB is parallel or equivalent to autoimmune hemolytic anemia. 3 hours later, he had petechiae, fever, chills, headache, and he also has disorientation. And when he did CBC for himself, the platelet was 9 after 3 hours, which is last for 4 days, and he recovered after that. And actually, this is his count among many healthy individuals. So he confirmed that we are dealing with autoimmune disorder, and later study proved that we are dealing with IgG against glycoprotein 2B3A and glycoprotein 159. Treg, as I said, is a subset of peripheral T cells, which is responsible mainly of suppression of immune-mediated autoantibody. And Nishimoto in 2012 did a very interesting experiment, which might have therapeutic implication actually, when he brought about 70 mice, and he depleted them from Treg cells, which marked by CD4 and CD25 cells. And in the first phase of the study, 40% of Treg deficient mice became thrombocytopenic and displays IgG antiplatelet antibody. In the second phase, he transferred purified Treg to those mice, and it prevented thrombocytopenia. So he proved that the essential role of Treg in ITB. So now actually we have summarized the pathophysiology of ITB or autoantibody and impaired thrombopoietin production and role of Treg in ITB. So I will go to the diagnosis of ITB just to sake of. Actually, as I said before, autoimmune hemolytic anemia has been used as a prototype for ITB because there are many similar topics, there are many similar aspects between those diseases. They are all autoantibody-related hemolysis, which is being proved by many studies. But when it comes to the biomarkers, soon we discovered that we are comparing orange with apple. Because the hemolytic marker like high LDH, Retex, bilirubin has been standardized and it's been validated since long time. So we know that if we are dealing with hemolytic anemia and we prove it with that, we are dealing with autoimmune hemolytic anemia. However, the story is totally different when it comes to the platelets and when it comes to autoimmune thrombocytopenic purpura, because the platelet is technically more difficult to isolate, to wash, to investigate. And this is why still we are struggling to validate and to standardize the platelet biomarkers, the structure like MBV, like reticulated platelet function, like immature platelet fraction. However, now the new automated analyzers will make our life easy, and I will talk about this later. The major issue here is that has high sensitivity and high specificity, but MIBA assay, which as the gold standard to as a serological test to prove that we are dealing with ITB, have low sensitivity, but it is having high specificity. High specificity because it targets glycoprotein 2B3A and glycoprotein 1B59. So if we are dealing with autoantibody against those antigens, usually we are dealing with ITB. However, the sensitivity is a major issue here, and I will address it later. So which make still the ITB as the diagnosis of exclusion. And being diagnosis of exclusion, we have to do all this investigation, not to prove that we are dealing with ITB, but also to exclude all other secondary causes. A bone marrow, usually it is not recommended unless the patient has above 60 or abnormal findings, or if there is any suspicion of myelodysplastic syndrome. So all these investigation actually just to rule out all other differential diagnoses. Clinical presentation, I think you are all familiar with this. Patients usually present with petechiae, purpura, and many of the patients, they might present asymptomatic because, routine screening now is common. And you see, usually they present with isolated thrombocytopenia. MBV, which is main platelet volume equivalent to MCV, is usually high, and BDW also is high, which is equivalent to RDW. Those are new platelet inducers, which is quite helpful in diagnosis of ITB. You can see here that this is giant platelet, which will be calculated as RBC according to the automated analyzers. And this one of my patient, actually, it is one of the most interesting cases that I ever encountered in the last 10 years. Ali was 10 years old boy referred from Al Jof Hospital as a known case of refractory ITB. Actually, he failed steroid, he failed IVIG, and he has been referred to us in King Fahd Medical City for splenectomy. And he has mild splenomegaly, so they have suspicion that they are dealing with hypersplenism. But the most interesting issue here in the presentation that he was bleeding while platelet count is more than 70. So when we do CBC, we discover that he has mild hypochromic macrocytic anemia, which is expected because he is either platelet was 95, MBV was high, and BDW was normal. And if you see this platelets, those are large platelets, but they are morphologically, they are not normal. Those are too gray to be considered as normal platelet. So BFA 100 was normal, and aggregation study was, BFA was not done. And when we did a bone marrow, he had mild fibrosis. And actually, we suspect that he could have gray platelet syndrome. And when we do electron microscopy, we discover that he's deficient of alpha granules. And the alpha granules, by the way, is the most abundant granules in the platelet. And this is the normal platelet, and this is the gray platelet syndrome. So he has gray platelet syndrome. He has been treated as ITB maybe since 5 years. So we requested for Nabil 2 gene, and it came to be positive. So we confirmed that we are dealing with gray platelet syndrome. It was not ITB. So sometimes the diagnosis is not straightforward. And at Jove Hospital, Prince Abdulaziz bin Saad Hospital in Jove is secondary to tertiary hospital. So despite that, they missed it. Now, the new parameters of new indices of platelets, like reticulated platelets, are promising actually, and they are quite helpful now. And many studies prove that they have high sensitivity and high specificity to predict and to diagnose ITP patients. So reticulated platelets are immature, newly released platelets, which has to contain more RNA. Actually, it is equivalent to reticulocyte and RBCs, and they can be counted by flow cytometry, and more importantly, they can be calculated also with fully automated analyzers, like what we have now.
So please try to wrap up in 2 minutes.
Okay. Immature platelet fraction is automated method to detect reticulated platelet, and you can see this is normal patients, and those are normal platelets. A normal individual, you have about 7 to 8% immature platelets. But here, this patient is thrombocytopenic, and the majority, and he has actually major part of his platelet are immature platelet. And a study published in Platelet 2015, Adli and his colleague proved that immature platelet fraction is significantly higher than, and statistically significant higher than non-ITP patients, and cutoff value of immature platelet fraction with 9.4 could be diagnostic for ITP patients with sensitivity of and specificity around 90%. Serological test, we have two types of serological tests: direct measurement of platelet-bound IgG, which is a variety of technique available. However, they are complex, labor-intensive, and they have huge variability of results. And the main drawback actually comes from that this is the normal cut point of each individual. Actually, the normal antigen in normal platelets, it varies from 100 to 20,000. So it is more of research, and it has no clinical utility. The most and the gold standard for diagnosis and confirmation of diagnosis of ITB is MEBA assay. MEBA assay is a qualitative technique for platelet antibody identification. It is still the gold standard technique used to detect glycoprotein 2B3A. However, the major issue here is the sensitivity. And the problem in sensitivity does not come from the technique itself. It comes from heterogeneity of the disease, because autoantibody might be against antigens rather than glycoprotein 2B3A, and sometimes low titer or sequestration of the antibody, and presence of another mechanism, which is cytotoxic T cells, which complicate the issue and reduce the sensitivity of MEBA assay. So those are my last slides, just to make Prof. Amr happy. ITB is clinical expression of a variety of thrombocytopenic disorder with different underlying mechanism. We know that we have different underlying mechanism. The role of Treg cells has to be explored further as primary event, not a minor contributor. And the study actually has to be moved from translation study to clinical trial study, because Treg might have therapeutic application, and until that level, ITB remains diagnosis or exclusion. The ideal test has not yet been developed as current method. All the current test method needs to be improved. Response to therapy, steroid, IVIG is the best diagnostic parameter. And platelet autoantibody, again, we know that it has high specificity. So if it came to be positive, that means that we are dealing with ITB with 90% specificity. However, the sensitivity is 50%, and the low sensitivity does not come from MEBA itself. It comes from the heterogeneity of the disease. So we have to invent we have to be innovative and inventing a new test to test for ITP and to confirm the diagnosis of ITP. New platelet indices has to be integrated with other parameters just to make our life easy. So thank you very much.
Thank you very much, Dr. Mansoor, for this elegant presentation. We will have the question and answer session at the end after all the three presentations. I would just like to remind the audience that this webinar is being recorded and it will be available on the SSBD YouTube channel as well as on Twitter. Now I have the pleasure to introduce our second speaker. Dr. Hazzal Zahrani is a consultant hematologist and head of the section of adult hematology at King Faisal Specialist Hospital and Research Center at Riyadh. And he is mainly interested in hemostasis and thrombosis. And he has done a lot of work. He is involved in many national and international trials, and he has more than 50 publications in journals. Dr. Hazzal Zahrani is going to talk about, going to tell us that how I treat ITP. Dr. Hazzal, please go ahead. You have 20 minutes. It seems we will not be able to see Dr. Hazzal Zahrani because
can you see my slides now?
Please go ahead. Yes, you can see your slides. Please put it on slideshow.
Alhamdulillah, it's a great pleasure and honor to be with you colleagues and present on the topic of treatment of ITP. This is the outline of my presentation: introduction, initial treatment, subsequent therapy, refractory cases, and a very brief overview on emergency management in ITP pregnancy and COVID-19 associated ITP. As you all know, ITP has been described around 300 years back, and the splenectomy was used to treat ITP more than 100. And it remained with the steroids the standard of therapy until around 20. And then around 12 years back, we had the PPR, and before that, rituximab was introduced to treat cases of ITP. The treatment of ITP, the goal is not to normalize the platelet, but to have a safe platelet count that will prevent bleeding and resolve acute bleeding episodes. The usual safe number of platelets that is commonly required is more than 20 to 30, and it may vary depending on patient's lifestyle. And in those who are older than 60, they may require higher target platelet count, and also in patients who are on other concomitant medications may require higher platelet count. We should aim for minimizing the toxicity of any intervention used to treat these patients and improve their quality of life and reassure them and try to advise them to continue their normal life activities much. So who should be treated? As we said, the people who have a platelet count of less than 20 to 30, and there are many factors that influence our treatment decision, including the extent and severity of the bleeding, the age of the patient, as we said, where older patients may be on medications that may make their bleeding tendency higher, like NSAIDs or antiplatelets or anticoagulants. Females in their reproductive age where their menstruation may have bleeding lower platelet count than usual. Comorbidities like infections and other hemostatic defects from our surgery. And then there are several other complications of therapies that can, modify the choice of treatment that we choose for each individual. We mentioned earlier activity and lifestyle. Some patients present with fatigue that correlates to the platelet count. This should be taken into account and maybe an indication to raise the platelet target in these. Side effects of therapy will also affect the decision and choice of the therapy. And of course, during interventions and procedures, we will have to modify the target of the platelet count to a safe level. Accessibility to care is an important issue. You might have a patient who comes from the far north. That will not be, easy managed like a patient who comes or lives around 20 to 30 minutes drive from the hospital.
Hasta, can you raise your voice a bit, please? Because there is concern. Many people can't hear you. Thank you.
Sorry. Can you hear me now?
Yes, it's better now. Please go ahead.
Yeah, I think we should also keep in mind the patient's expectations and preferences and anxiety. The choice of therapy will depend on the availability of the medications in the country or institution where when one is practicing, and the resources and the insurance, or if this is a publicly funded healthcare system. So the newer drugs are easier to prescribe in a publicly funded healthcare system than in private hospitals, especially if the patient has no insurance. The new drugs will reduce the chance of being immune suppressed and have a very good level of evidence, but they are more costly. Now, who should be treated in inpatient and who should be treated as outpatient? Most of the patients will be treated in the outpatient setting. And we admit patients who have active bleeding or have other coexisting conditions like platelet count of less than 30 at the time of presentation, concomitant anticoagulant therapy, and patients who are clinically judged to be requiring close clinical monitoring. This is the graph from the International Consensus Report on the management of ITP published in December last year. And it lists the initial therapy versus subsequent therapy, and they list them in an alphabetical manner. So initial therapy in all guidelines is usually steroids, and these are the types of steroids that we typically use, either dexamethasone, methylprednisolone, or prednisone, IVIG, and anti-D. I know some pediatricians prefer to use IVIG, especially in younger kids, to avoid the possible effect of masking an early phase of ALN in some of these patients. So if they don't respond to IVIG, they may treat with and then do a bone marrow and include plus. So newly diagnosed patient who has an indication to be treated and no contraindication to steroids like diabetes or psychiatric illnesses or active infection will typically be treated with steroids, prednisone 1 milligram per kilogram per day for around 2 to 3 weeks, or dexamethasone. We give 20 to 40 milligram per day for 4 days, and this is repeated up to 4 times. If the patient responds and the platelet count improves more than 50, then the steroids typically are tapered and stopped within 8 weeks. And if the patient requires a low dose of steroids, and that typically is around 5 milligrams, that can be maintained as long as the patient platelet count is remaining in the level that you want. If no response is seen within 2 weeks, steroids can be tapered and stopped quickly, and IVIG can be used, or anti-D. The other indications for IVIG include bleeding and high risk of situations where there's high risk of bleeding of such procedures. So I tend to use more dexamethasone than prednisone, and I use 20 milligram daily for 4 days in older patients. And meta-analysis of high-dose Dexa versus prednisone showed no difference at 6 months in the response rate, but Dexa had a faster response with possibly fewer additional toxicities. If you decide to use Dexa and you predict that the patient will require a longer course of dexamethasone, use prophylactic acyclovir and or vaccine. The addition of rituximab to dexamethasone has been studied in 5 studies, and it increase the initial response rate, but after 6 to 12 months, there is limited evidence of sustained response. We only use very high dose of steroid, like 100 milligram methylpred or 1 gram, in emergency situations where there's severe bleeding, and it is said to have a response of up to 80%. Now, IVIG is a very costly medication. One of my colleagues in the private practice says that a single course costs around 60,000 Saudi riyal. So we have to select patients who are candidates for IVIG. And this is from a study published in Peer-Reviewed Journal of Hematology. It's showing that if a patient scores more than 8 out of these scoring items, then they are candidates for IVIG. So these are patients who are at risk of increased bleeding, like age more than 75, generalized petechiae and ecchymosis, patients who have hemorrhagic poly and spontaneous gum bleeding, major GI or urinary bleeding, or central nervous system bleeding. These are patients who are requiring or should be treated with IVIG. Now, after this initial therapy, if the patient does not respond, which is not uncommon and is seen around 70 to 80% of patients, and if you cannot maintain the platelet count at a safe level for with a low dose of steroids, then other medical therapies have to be used, like rituximab and TPO receptor agonists. And there are new other drugs that are not available in the kingdom, including fostamatinib and avatrombopag, that Dr. Samkari will give us details about. And then there are many other drugs that have lesser evidence-based data, and these include azathioprine, cyclophosphamide, cyclosporin, danazol, Lapson, and Celsip, and Velcade, and others. Splenectomy is usually deferred for more than 1 year because many patients, or up to 1/3 of patients, will achieve remission by 1 year. And the recent guidelines from ASH, the International Consensus Group, the Working Group of Germany, the Australian investigators, Dutch investigators, and our guidelines in Saudi Arabia, say if the platelet count remains suboptimal and by persistent and chronic ITP beyond 3 months, and chronic is beyond 12 months, then the recommendation is to use thrombopoietin receptor agonist in patients in whom glucocorticoids have failed, and to use rituximab and splenectomy in those in whom TPO agonist has failed. So this is a very quick listing of the different therapeutic agents. Romplastin is usually given at 1 to 10 microgram per kilogram per week subcutaneously, and the response rate is 40 to 60%, and up to 30% of patients will maintain response even after discontinuing the medication. The common side effects are headache, muscle aches, and there is a possibility of disease thrombosis and myelofibrosis. L-Thrombovag, I think, will be covered in details by Dr. Samkari. Usual dose 25 to 75 milligram per day. Response is achieved within 2 weeks, and response is seen around 60% of patients. And around, again, 30% of patients will have a maintained response after stopping the medication. Side effects include GI upset, transaminitis, cataract, and thrombosis, and myelofibrosis. The very important point with regards to the efficacy for Thrombovag is the dietary relationship, where it has to be given 4 hours after and 2 hours before any meals containing categories like iron and calcium. Rituximab is given at either 375 milligram per meter square or at a lower dose of 100 to 200 milligram weekly for 4 doses, and it acts within few weeks, and usually you achieve a response in around 50 to 60% of patients, but in long term, at 2 years and 5 years, around 25 to 30% of patients have maintained response. The treatment can be repeated in a few years if the patient did not respond to or has relapsed. The side effects include infusion-related reactions and infection. It should be avoided in patients with active hepatitis B. Imuran is given at 1 to 2 milligram per hour, per kilogram per day, and it acts within 6 to 12 weeks. We see a response around 30% of patients. It can cause cytopenias and weakness and sweating and cramping. MMF is given at 500 milligram BID and increased gradually to 1 gram BID. It again takes time to work, up to 2 months, and response is seen in 30 to 60% of patients. Danazol is given at 400 to 800 milligram daily, and it acts within 3 to 6 months, and response rate is seen around 1/3 of these patients. And side effects are hirsutism, acne, amenorrhea, transaminitis, and should be avoided in patients with prostate cancer. Dapsone, I use the Dapsone and Danazol very frequently, especially if the steroids are used initially, because Dapsone is a good anti-PCP therapy if the patient requires longer course of steroids. And I use Dapsone after excluding G6PD deficiency, and we see a response rate of around, the reported response rate, 30 to 60%. To be honest, in my practice, I have seen very rare response to Dapsone. We only use venic alkaloids in emergency situations where I need a quick rise in platelet count, and this is seen by around 7 days in around 2/3 of these. In patients failing the initial therapy, one should reconsider the diagnosis, as Dr. Jabri mentioned. It could be dealing with congenital thrombocytopenia or other diagnosis. If bone marrow has not been done initially, then repeat bone marrow or an examination of the bone marrow has to be performed. Reassess the need of treatment. Maybe the patient will do well with the platelet count of 15, 17 in this range, or even lower. I have during my training in Canada, we used to see patients with a platelet count of 7, 8, and they are doing fairly well because the more aggressive therapies we give, the more likely that you will end up with toxicity. So we have to be careful. I think these days I have never, in the past few years, seen patients with chronically low platelets below 10 with the introduction of the TPO agonist. So we have to weigh the risk and benefit of the therapy and consider therapies that I mentioned earlier. Splenectomy, if it has not been done, can be considered, and if it was done, look for accessory spleen by either CT scan or NDM-labeled platelet scan. And switching between TPO agonists sometimes help and works, and many patients it can be managed by just supportive care in the form of platelet transfusion or tranexamic acid. And if you have the facility to include these patients in clinical trials, that is a good option. I think anticholinergic agents are very good to use in acute and major severe bleeding or dental procedures, and in patients who have sustained and persistently low platelet count. But you have to watch and warn the patient about the risk of thrombosis. Splenectomy, as we said, is usually delayed 1 to 2 years, but it has the highest long-term remission rate of around 60 to 80%. Before splenectomy, we have to vaccinate these patients against Streptococcus, Neisseria, and Haemophilus influenza. And after splenectomy, we have to use antibiotic prophylaxis in the form of penicillin BK 500 milligram daily. We continue this for years. And we have to also use the chemical prophylaxis if the platelet count is more than 30. And I start yearly around 8 to 12 hours after the achievement of this platelet count, if the patient is stable and no out of this clinical bleeding. Long-term complications include thrombosis and infection. For life-threatening bleeding like acute CNS bleed, GI bleed, and GO bleed, if the patient is on antiplatelets or anticoagulants, they have to be stopped and they have to be stabilized. and if the patient is female in the menstruation period or having a major urinary bleed, your ovulations, immunosuppression is very important. We use IV steroids and IV immunoglobulin, platelet transfusion, and antipyretic agents, and TPO agonists in major life-threatening bleed. Platelet transfusion raised the platelet count to more than 20 and around 40%. I use factor 7 in cases of CNS bleed. Otherwise, even in major bleeds in other sites, we don't use. So if by 24 to 48 hours I have no response, we can consider anti-D or vincristine or vinblastine. There are several new therapies in the horizon in management of ITP. We don't have avatrombopag in Saudi Arabia. We also don't have postamatinib. These two drugs have already been approved by US FDA for treatment of refractory ITP. Rilzabrutinib, although is an oral investigational proton tyrosine kinase inhibitor, has reached very late clinical trials and granted FDA fast track designation for treatment of ITP just, I think, a week back. Another target for therapy in refractory ITPs is the neonatal FC receptor. And this is the target for interface between the immune effector cells, the macrophages in the spleen, and the antibody-coated platelets. It accelerates the degradation of autoantibodies that drives ITP. So basically, the FC receptor inhibitors will allow degradation of these of antibodies. And this approach is now being used in also in other autoimmune diseases like myasthenia gravis and Graves' ophthalmopathy and neuromyelitis optica.
Please try to wrap up in 2 minutes.
This receptors include efgartigimod and batoclimab. These are investigational drugs and are in, I think, phase 2 to phase 3 clinical trials, and rozanoliximab. Another drug that may be used in the future for ITP is Thrombocytopenia, and I'm only aware that a study in ITP has been terminated by the company, and maybe Dr. Samkari can comment. In pregnancy, a platelet count less than 80 will make you suspect ITP, but you have to rule out other conditions that are peculiar to pregnancy, including microangiopathies and coagulopathies, and HELLP syndrome.
Dr. Hazza, please try to wrap up quickly. Now we are running short of time, please.
Sorry?
We are running short of time, so please try to wrap up quickly.
Okay. So we target a platelet count of more than 30 if there is no bleeding, and if it is less than 30, you like in non-pregnant patients, initial therapy, steroids and IVIG. In refractory patients, you can use combination of prednisone and IVIG, and high-dose methylprednisone can also be considered. Rituximab is in very severe cases, and if you use it, watch for neonatal immune suppression and infection. We only have used TPO agonists in very late pregnancy, but in very few patients. If splenectomy is required, it usually will be safest done in the second trimester. And we don't use denecalcloid. For delivery, we keep platelets above 50, and we are for regular delivery, and for regional anesthesia more than 80. And you should avoid NSAIDs, and you make sure you use mechanical thromboprophylaxis. This is usually managed in combination with the obstetrician and neonatologist and pediatric ICU and pediatric hematologist. For bridging, we typically use IVIG, but recent studies that Dr. Samkari published in 2019 on using TPO agonists as a bridge to for surgery, and a recent trial in March this year, 2019, also showed that L-Thrombobag given 3 weeks pre-op will do as good in preparing patients for surgery as IVIG. And this is our target for platelet count. For most dental procedures, it's 30, but for complex extractions, more than 50. And if the patient is on anticoagulant, we keep them, their platelet is more than 50. They're on dual antiplatelet is more than 50 to 70. For major surgery, the target platelet count is usually 81. Last slide I have is on ITP and COVID-19 patients. And any talk these days without mentioning COVID is considered deficient. This is a meta-analysis of 45 patients with ITP in COVID-19 patients. And here they said that 71% of these patients were older, and most of them had severe disease. 7% were asymptomatic, and this is very interesting. So like when we used to say any patient present with ITP, consider testing for HIV. I think this also applies here. If you have a patient with low platelet, even if he is asymptomatic, consider testing for COVID-19. And 20% of cases happened 3 weeks after the onset of COVID-19. One patient died with intracranial bleed, one had Evans syndrome, and they responded to steroids and IVIG, and there were a few cases reported treated with TPO. But you have to exclude other conditions like HLH and heparin and drug-induced thrombocytopenia, other infections, and autoimmune diseases and other underlying disorders. So in conclusion, ITP management in adults is challenging. Newer therapies allow delay of splenectomy. Refractory cases need a trial of different lines of therapy, typically in combinations. Several new therapeutic options targeting new mechanisms of ITP pathogenesis are expected in the coming years. And thank you very much for your attention.
Thank you very much, Dr. Hazar Zahrani, for this comprehensive review of ITP treatment. So without any delay, I would like to introduce our last speaker, our international speaker, Dr. Hani Al-Samkari, is a staff physician at the Division of Hematology Oncology, Massachusetts General Hospital, and he is a faculty member at Harvard Medical School. He's a member of several international committees and societies, and he's also editor of Blood Advances. He's going to talk about TPO agonists, the similarities and the differences between different types of TPO agonists. Dr. Hani, please go ahead.
Wonderful. Well, thank you very much for that very kind introduction. It's a pleasure to speak along with Dr. Al-Jabri and Dr. Al-Zahrani. The topic of my talk today is going to be dissecting some of the differences and the similarities between the various thrombopoietin receptor agonists. All right. So we're going to review first some of the clinical data and pharmacology for the thrombopoietin receptor agonists, and then we're going to talk about perhaps optimal clinical scenarios for selection of one agent over another, and then we will have some question and answer. So there are 4 commercially available thrombopoietin receptor agonists worldwide. These are all 4 of these are available in the United States, and as was just noted, avatrombopag is not yet available in the Middle East. Lucitrombopag also not yet available in the Middle East and is not yet approved for ITP. Unclear if that will ever happen. In the United States, we have 3 agents that are approved for ITP: rimiplostim, L-trombopag, and avatrombopag. Rimiplostim is the peptide agent, and the other agents are small molecule oral agents. Rimiplostim acts at the extracellular domain of the thrombopoietin receptor, whereas all of the small molecule agents act at the transmembrane domain, and I'll talk a little bit more about that in a moment. Rimiplostim is the subcutaneous agent. The other 3 are oral. I'm highlighting kind of differences here. Rimiplostim, as we know, is given weekly, and the other agents are given daily, although oral TPO receptor agonists can potentially be given less frequently than daily, and I'll get into that. So L-trombopag, as was already alluded to, has food interactions that really can inhibit its absorption, and these must be paid attention to when using this medication. And patients need to be compliant with dietary restrictions. In terms of indications right now, per the US FDA, so rimiplostim is approved for immune thrombocytopenia in both adults and children. L-Trombopag, also ITP in adults and children, also hepatitis C-associated thrombocytopenia in patients receiving certain antiviral medications, and severe aplastic anemia. Avatrombopag and lucitrombopag are both approved for periprocedural thrombocytopenia in patients with chronic liver disease. And avatrombopag, as I mentioned, is also approved for ITP, but just in adults and not in children. Lucitrombopag is somewhat sort of the odd man out here in that it's not approved for ITP. Right now, it just has the single approval for periprocedural thrombocytopenia. So since this is an ITP talk, we will focus primarily on rimiplostim, L-Trombopag, and avatrombopag. So as I mentioned, rimiplostim binds to the extracellular domain of the thrombopoietin receptor. This is represented in panel C, ROM, or rimiplostim binding to the extracellular domain. The oral TPO receptor agonists bind to the transmembrane domain, so a completely separate domain of the TPO receptor. And it is thought, and it has been demonstrated in studies, that there is some difference in the action of these agents based on the differential site of binding. It's felt that oral TPO receptor agonists increase platelet production and megakaryocyte proliferation about equally to a certain extent, whereas rimiplostim primarily increases megakaryocyte proliferation. Now, of course, you increase megakaryocyte proliferation, you increase platelet production. So the downstream consequences are the same in that the patients have elevated platelet count, but there is some difference in the site of binding and at least potentially the early events that follow from that binding. So I have a table here of the randomized trials that have evaluated thrombopoietin receptor agonists in ITP, the phase 3 studies. And there are quite a number of them listed. And most of them are for L-Trombopag and rimiplostim, which have had each have had a number of randomized trials to evaluate their safety and efficacy in ITP. There is one randomized trial, phase 3 trial, I should say, randomized phase 3 trial that has been published evaluating avatrombopag, and that's the one at the bottom here. You know, the one area where these agents are quite similar is their performance in clinical trials. So, you know, despite some of the differences I will talk about momentarily, at least in the clinical trial setting, the response rates were overall pretty similar. And when you use these agents in kind of the earlier line setting in patients receiving second or third line treatment, you're going to see response rates kind of in the 60 to 80% range for any of them. And that's generally what the clinical trials showed. Patients who are splenectomized respond just like patients who are not splenectomized, perhaps a slightly lower response rate, but that may be more related to them having more kind of refractory disease, having been splenectomized, but still requiring treatment. The safety profiles of the agents, we'll talk a little bit about some of the differences. This was already alluded to in the prior excellent talks. These agents are generally safe, and most patients have no side effects. The most common side effect, at least in my clinical practice, is no side effect. We find, you know, adverse events listed in trials. You know, the vast majority of patients had a quote unquote adverse event. Whether or not that adverse event is related to the drug is a different story. And as for using these agents in clinical practice, most patients tolerate them very well. L-Trombopag has a signal for hepatotoxicity, which we'll talk about. And there is a theoretical increased risk of thrombosis. Now, I think it's important that I note on this slide where I talk about clinical trials that in all of these clinical trials, there was not a statistically significantly higher rate of thrombosis in the thrombopoietin receptor agonist arm over the placebo arm for any of these agents in any of these trials. So There is observational data that suggests that there may be increased thrombosis rates, especially when you treat patients over periods of time, but at least when compared with placebo in shorter clinical, randomized clinical trials, we don't have a statistically significantly higher rate of thrombosis in ITP. So, we have a lot of treatment options, and we just had an excellent overview of all of the different options in ITP. So, when do we use these agents? Right now, they're firmly considered second-line treatment agents, and certainly if rituximab is used in the second line, we go to a TPO receptor agonist in the third line, and so on and so forth. They really can be used at any line, and they're efficacious in just about any line, although their approval is for patients who have failed at least one prior treatment. And certainly, unless there are strong contraindications, we treat with corticosteroids in the first line. So I have a number of other agents here, most of which were already discussed. The response rates that I mentioned before are not going to be as high in patients when you're using thrombopoietin receptor agonists in patients who have received multiple prior lines of therapy. If they're on their fifth line or their sixth line or the second line of treatment, they're going to be lower response rates if you use a TPO receptor agonist in that setting. But the numbers you're going to see in clinical trials and most studies are in the earlier line setting. So, I have this graphic here really to just highlight, which again has been addressed by the prior speakers as well, the complex pathophysiology of ITP and how each of our therapeutics enters in at a different place in this pathophysiology to intervene and try to prevent platelet destruction by one mechanism or another. In the case of TPO receptor agonists, they, along with steroids, are the only agents that really increase platelet production in the bone marrow. And thrombopoietin receptor agonists, in addition to increasing the production of platelets, they also reduce megakaryocyte apoptosis, which is typically induced by platelet autoantibodies binding to GP2B3A, 1B9, and other platelet glycoproteins that are also present on the megakaryocyte surface. So, considerations for thrombopoietin receptor agonist use in ITP. As I mentioned, they can be used really after any disease duration, but typically after at least failure of one other therapy. At least that's the approval. Response rates and adverse events profiles are really similar in patients who have ITP for less than 1 year versus ITP for greater than 1 year, which initially these agents were for chronic ITP, but have since earned approval in earlier stages of the disease because the response rates and adverse event profiles are similar. When we get to this point, we're primarily making a decision between a thrombopoietin receptor agonist and an immunosuppressive agent. The TPO receptor agonists in general have higher response rates than immunosuppressants, certainly higher than rituximab when given the second line setting. The flip side is the potential theoretical higher thrombosis risk. And in the case of using these agents versus rituximab, the need to give a chronic therapy. Of course, immunosuppressants increase infection risks, which in turn can cause an ITP exacerbation if patient gets an infection. So these are things that we sort of weigh and we consider. Right now, we don't have a great way, we don't have really any way to understand whether a patient's ITP is primarily driven by more platelet destruction or less platelet production, or if it's kind of evenly balanced between the two. As we understand more about this disease and understand more about specific patient's predominant pathophysiologic mechanism, we may start choosing treatments on that basis. Right now, we choose treatments based on what's available to us and adverse event profiles and response rates that we see in studies of large groups of patients. So, I have here avoid L-traumapag in patients with known liver disease. This is, I'll discuss more of the data behind this. I mentioned it does have known hepatotoxicity, but also In a couple randomized trials of patients with liver disease, these L-Thrombopag did appear to increase thrombosis rates, in particular portal vein thrombosis in these patients. This was not seen with other trials in liver disease with other TPO receptor agonists. So that's something to consider, a difference that relates to L-Thrombopag. It may be optimal to use the patient's endogenous thrombopoietin level in clinical decision-making. This has been shown in a couple of studies. We did some work in this area. The blue line is the predicted response rate for ribiplastim based on thrombopoietin level, and the red line is for L-Thrombopag. And so Dr. Al-Jabri had shown a very elegant study that was done showing essentially normal rates of endogenous thrombopoietin in patients with ITP. Generally, they're either normal or slightly elevated. It turns out that patients who do have normal rates, which in this assay is less than 100 picograms per milliliter, the response rates were very good, essentially 90 to 100% for both agents. Once the endogenous thrombopoietin level in patients with ITP rises above this level, you see a reduction in response. And this is similar to what we see using erythropoiesis stimulating agents in patients with anemia. Higher EPO levels predict for a lower response rate, and it appears to be true about TPO levels as well with thrombopoietin receptor agonists. One difference is that we found that patients receiving ribiplastim were more likely to respond at higher thrombopoietin levels than patients receiving L-Thrombopag, who had a more sort of precipitous decline in their response rates as TPO levels increased. So just to briefly talk about dosing for ribiplastim and L-Thrombopag, the ribiplastim label states to start at 1 microgram per kilogram per week and to increase weekly based on platelet counts at a rate of 1 microgram per kilogram per week. In my experience, this is starting too low and going too slow for the vast majority of ITP patients. Clinical trials, including a randomized phase 3 trial of ribiplastim and ITP, started at 3 micrograms per kilogram per week, and that is what I start my patients at. If somebody is severely thrombocytopenic, then I will start them at 5 micrograms per kilogram per week. I don't hesitate to increase, I don't hesitate to titrate by 2 or more micrograms per kilogram per week, depending on the clinical scenario, rather than the 1 microgram per kilogram per week that is noted in the prescribing information. If someone is, clinical emergency setting and we need to raise their platelet count desperately, I won't hesitate to start at 10 micrograms per kilogram per week. Again, these agents don't work quickly, so this is not, our first choice. We're talking about patients that have failed IVIG and potentially other treatments. I don't hold doses for thrombocytosis unless the platelet count is greater than 1 million. The reason why I don't do this is holding doses tends to lead to a lot more volatility, a lot more up and down, rapid swings in the platelet count. And so what I do is I dose reduce by 1/2 to 2/3 if a patient has a really, really high platelet count, close to 1 million, and I'll dose reduce it by less if they're just slightly in the thrombocytosis range, between 400 and 600,000. And I've had a lot better success with that approach. In terms of L-Thrombopag, it started at 50 milligrams per day in all except for patients of East Asian descent, patients who have chronic liver disease, and children who get 25 milligrams per day. Patients with chronic liver disease, I typically avoid L-Thrombopag for the reasons I already mentioned. Technically, 75 milligrams per day is the max dose of L-Thrombopag in ITP, although you can go higher. There is scant evidence for this. In patients with aplastic anemia, of course, we go up to 150 milligrams per day. One thing to note with L-Thrombopag, especially at the high doses, is that you can get plasma, skin, and sclera changes. This is more with the aplastic anemia doses, but can happen with ITP dosing. This actually can interfere with bilirubin measurement, which is especially problematic in some patients because hepatotoxicity, which can impact the bilirubin, is a known side effect of L-Thrombopag, And the way that this interferes with measurements is actually makes the bilirubin appear falsely low. So that's something that needs to be considered. It's pretty clear if this is happening to somebody by looking at their plasma. I'll show you in a moment. In patients getting L-Trombopag, you have to monitor their LFTs. About 11% in clinical trials, and a pooled analysis of clinical trials of L-Trombopag, 11% of patients did develop LFT abnormalities. L-Trombopag is an iron chelator as well, so that's something that needs to be considered. Patients with long-term L-Trombopag treatment, in particular children getting L-Trombopag, can develop iron deficiency. So need to consider that and potentially treat with iron. So this is a patient of mine that developed red plasma, a reddish-brown discoloration of their plasma from L-Trombopag. This can make the sclera of the eyes appear darker or muddy. In patients with very fair complexion, can make the skin even look darker. And I have this on the left, the patient getting L-Trombopag, on the right, regular plasma. Avatrombopag, as I mentioned, a newer thrombopoietin receptor agonist. The dosing in ITP is a bit different. Rather than changing the dose level of going from a different amount of the drug given per day, the drug is actually dosed by giving it a different number of times per week. 20 milligrams once daily is the starting dose. This can go up to 40 milligrams once daily if patients need. But if 20 milligrams is too much, which it certainly can be for many patients, we can dose 3 times a week, twice a week, once weekly with this drug. This actually can be done in L-Trombopag as well. Both of these drugs have very long half-lives, relatively speaking, about 20 to 35-hour half-lives. And so based on the pharmacodynamics of thrombopoiesis, in which you really need a week to see much change, there's about a week lag between use of the medicine or change of the dose of the medicine and what we see in terms of the platelet count response. With L-Trombopag as well, you can go down to using you can keep the pill strength the same at 50 milligrams per day or 75 milligrams per day, and go down to 5 times a week, 4 times a week, 3 times a week. It can be dosed in that way. You can modify the dosing in that way rather than changing the pill strength. So with that kind of overview, I'm going to highlight some other differences between these agents over a course of a few cases to finish off my part of the talk here. So the first case, 34-year-old woman with chronic ITP on L-Trombopag presents for follow-up, was diagnosed with ITP 3 years earlier. After initial treatment with corticosteroids and IVIG, she relapsed and was started on L-Trombopag. She had done well on L-Trombopag 50 milligrams daily for the first 2 years with a platelet count in the 100 to 200,000 range. But over the past year, platelet counts had fluctuated dramatically. They were 20 to 40,000 over several weeks. And then she was up-titrated to L-Trombopag 75 milligrams. Then she was she was in the thrombocytosis range, 400,000 to 500,000, down titrated back to 50 milligrams. She was briefly back in the 100,000 to 200,000 range for a few months. And then she was back down to the 20 to 50 range. So what happened here? She says she never misses a dose of L-Trombopag. She takes it every day in the morning. On further counseling, she admits that despite what she was told before, she was taking L-Trombopag with her breakfast, which included eggs, milk, and buttered bread every day. She states that she initially was able to adhere to taking L-Trombopag on an empty stomach as instructed, but after 2 years, she started to forget, and the only way she would reliably take it was with her breakfast. This is a common, this is something we see commonly in patients that are on L-Trombopag for a very long period of time. We have Avatrombopag available, which does not have issues with dietary absorption. So this patient will switch to Avatrombopag, since maintain a platelet count of 100 to 200,000 without issue, and is able to take it with food. Avatrombopag actually absorbs well with or without food. So this is just highlighting an issue with long-term use of L-Trombopag, which we know from clinical trials, from the early phase clinical trials of both of these agents. When patients taking L-Trombopag took it with fat, a decent amount of dietary fat, which most any meal will have, or polyvalent cations like calcium, magnesium. This reduced absorption of L-Trombopag by over 50%. So these patients require essentially a 4-hour fasted window, or really 6 hours if 50 milligrams of calcium is consumed. This is not very much calcium, so it's present in a single serving of many dairy, grain, and vegetable products. Avatrombopag, as I mentioned, doesn't have this issue. And it's something just especially to remember in patients who are treated for long periods of time. I want to make sure to stay on time here. Second case, a 55-year-old man with chronic ITP presents for evaluation, was diagnosed with ITP 15 months ago, was initially treated with dexamethasone and relapsed. He then received rituximab, which controlled his disease for about a year, but then he subsequently relapsed again. He was started on prednisone, which improved his counts and transitioned to L-Trombopag. Unfortunately, he did not respond well to max dose L-Trombopag with counts in the 15 to 30,000 range. He's not interested in further rituximab. He wants a treatment that will maintain his counts reliably. Also would prefer to avoid romiplostim if he can, because he works full-time as a pilot. So let's talk about switching. So this patient received L-Trombopag, did not respond to it. What are the response rates when we switch from L-Trombopag to romiplostim and vice versa? Turns out they're pretty high. So this is a table that contains at least 24 studies of patients that received one thrombopoietin receptor agonist that were then switched to another, and in a meta-analysis of them and combining all of them, the response rate when switched from romiplostim to L-Trombopag was about 76%, and when switched from L-Trombopag to romiplostim was about 80%. So, not all of these patients were switched because they failed one. Some were switched just because they didn't tolerate one, or they didn't want to get subcutaneous injections in the case of romiplostim. But switch therapy is perfectly reasonable. And one thing that may come in here, which, this is certainly not proven in ITP by any stretch, but is something that we really have started to consider, is the relative potency of these agents. So this has not been rigorously evaluated in any clinical trial. A trial was underway to evaluate L-Trombopag versus Avatrombopag in 2011, but was discontinued due to failure to enroll. In healthy subjects, the peak platelet counts achieved with 20 milligram daily doses of Avatrombopag were approximately 3-fold higher than 75 milligrams daily doses of L-Trombopag, and they were 8-fold higher with 10 micrograms per kilogram of romiplostim. So it's not known if this holds true in ITP patients. These were healthy subjects, but I have witnessed this anecdotally in treating quite a number of patients with thrombopoietin receptor agonists. It's worth noting that, as I mentioned before, the response rate in the randomized trials of each of these agents is similar. So potency might only be important for patients with more severe refractory disease. So this is a patient, a 64-year-old woman who was treated sequentially, baseline platelet count around 10, and then responded to Avatrombopag, as you see, and then did not respond as well to L-Trombopag. And then if you zoom out and look at how she responded to romiplostim, we have, this is a single patient, obviously, and we would need to study this in large numbers of patients to confirm, but this is consistent with what we see in terms of the max response, the degree of platelet response in healthy subjects, with romiplostim having the highest potency, followed by Avatrombopag, followed by L-Trombopag. All right, and the last case I have to present to you today, a 66-year-old man with longstanding compensated cirrhosis and ITP presents for evaluation. He was diagnosed with chronic liver disease due to autoimmune hepatitis 6 years ago, at which time his platelet count was consistently 80 to 100,000. 1 year ago, he presented with diffuse petechiae, blood blisters in his mouth, and a platelet count of 2. He had giant thrombocytes on his peripheral blood film, and direct glycoprotein-specific platelet autoantibodies were quite positive, so a diagnosis of ITP was made. He was started on prednisone, which improved his platelet count back to his prior baseline. After weaning this, he relapsed, so was treated with rituximab, and he responded well to rituximab. However, less than a year after rituximab treatment, his platelet count today is 21,000. He has bruising on his arms and legs. So I'm just going to briefly touch on using TPO receptor agonists in patients with chronic liver disease. Long-term efficacy of of patients receiving these agents in chronic liver disease is not clear. We do have great phase 3 studies with avatrombopag and lusitrombopag to look at short courses around getting a procedure to raise a platelet count in preparation for a procedure, and both those agents appear to be efficacious and safe in doing that. But we don't have good data for treating patients with chronic liver disease for long periods of time, months, years, so on and so forth. What we do have for imiplastim suggests it's safe in this population. I mentioned the short randomized clinical trials with avatrombopag and lusitrombopag. There's also been a trial with eltrombopag, and I think these trials can actually help inform use of these agents in patients with ITP who also have liver impairment. The avatrombopag studies showed that the drug was safe and efficacious. Same with the lusitrombopag studies. They didn't find increased rates of thrombosis in patients receiving lusitrombopag or avatrombopag. But the eltrombopag study, the ELEVATE study, was halted prematurely due to excessive portal vein thrombosis in the eltrombopag arm. There was also a randomized trial in hepatitis C in patients who had hepatitis C related liver disease that found increased rates of venous thromboembolism in the eltrombopag arm. So, we extrapolate this data to ITP patients who have liver impairment, and we typically avoid eltrombopag in these patients and try to use riplastim or avatrombopag. Lusitrombopag and avatrombopag, as I mentioned, both safe in chronic liver disease, and lusitrombopag not approved for ITP, so this patient got avatrombopag. Riplastim would have been perfectly reasonable as well. So with that, I certainly want to thank you for this very kind invitation to give this talk, and I'm very happy to answer questions.
Thank you very much, Dr. Hani, for this comprehensive review of TPO receptor agonists. You really, compared all of them and gave a very comprehensive and detailed review. So we have few interesting questions. So there is one question. So this is directed to you, Dr. Hani. Would you consider TPO agonists in acute setting in ITP?
Yeah, so I think that's a great question. I don't typically use TPO receptor agonists in the acute setting unless somebody has failed to respond to corticosteroids and IVIG. But patients sit in the hospital with very low platelet counts, and they really want to get out, get home. I have a relatively low threshold. If it's been a few days and corticosteroids and IVIG haven't worked, I usually like to give riplastim 5 to 10 micrograms per kilogram just to get that platelet count up that's been very stubborn and get them out of the hospital. There is a modest thrombocytosis risk with this, but in my experience, really it hasn't been an issue. There are studies right now evaluating adding eltrombopag to corticosteroids up front in newly diagnosed patients. And those studies are potentially very promising, possibly increasing the early remission rates over use of steroids alone, potentially through an immune tolerance mechanism. So this is something that is currently under investigation. Clinically, it's really only in my practice when they fail steroids and IVIG.
Thank you very much. Now, there is another question, again directed to you. When would you label a patient to be TPO receptor agonist non-responder, considering that we have multiple TPO receptor agonists available?
Yeah, only once they've failed, in my view, they would need to fail all three to really be unresponsive to TPO receptor agonists. But in practice, I typically will stop after trying 2. So if somebody fails max dose riplastim and max dose eltrombopag, for example, then I would consider them TPO agonists. It's unlikely they're going to respond to avatrombopag in that setting, or at least I would try other agents before resorting to trying a third TPO receptor agonist. I do think it's important to up titrate patients to max dose and letting them receive that for, at least in terms of riplastim for a couple doses, eltrombopag for a few weeks before concluding that they have failed.
Okay, that's great. And actually, there is a similar question regarding TPO receptor agonists, but I suppose that is probably should be asked by a pediatric hematologist. The question is, do TPO receptor agonists have similar efficacy and safety profile in pediatric ITP?
Yeah, so for L-trombopag and rimiplostim, the answer is yes. Both agents have been evaluated in pediatric ITP, and they are quite efficacious and overall quite safe. There's always anxiety about the potential for giving a child an agent like this for long periods of time, if that could have any adverse events that we don't see in adults. That we haven't had that experience thus far with a few years of data with each agent. There also does not appear to be elevated rates of bone marrow fibrotic complications in either children or adults after long periods of treatment. So the answer, as far as we can tell, is yes. We don't have data yet for avatrombopag in children.
That's great. I have one question to you as well. Do you think that all the available TPO receptor agonists have a similar potential for thrombosis, or maybe one or the other is more likely to cause thrombosis?
I think that's a really great question. In ITP, I don't have any evidence available to suggest that one is more or less likely to have a thrombosis propensity. What some people will do is they will extrapolate the chronic liver disease patients, and how there have been a couple trials of L-trombopag that showed higher rates of thrombosis in the L-trombopag arm over the placebo arm. That is, certainly, that data is there. However, I would also point out that, there's just been a lot more trials of patients with L-trombopag than with the other TPO receptor agonists, given all the different indications. So, it might just be the fact that there have been more studies and more opportunity to find that. So generally, no, I don't think in ITP that there is good data to suggest that one is more likely to cause thrombosis over another.
So there is another question that when would you consider that whether the thrombocytopenia could be due to ITP or this could be purely due to chronic liver disease? I mean, in this situation, it may be difficult to differentiate which one is causing thrombocytopenia.
Yeah, and I'm happy to give my thoughts, and if my colleagues would like to opine as well. I mean, the way that I do this is if somebody has chronic liver disease and they have cirrhosis, and it's very clear, and they have mild thrombocytopenia, platelet count of 80, 70,000, something like that, or even 50, 60,000, I attribute it to the liver disease, and I generally leave it at that. If there is the thrombocytopenia out of proportion to what we would expect in liver disease, if somebody has a platelet count of 10,000, 15,000, or if they previously, like a case I showed, have a count in the 80,000 range and then they crash and it goes down to 5,000, then I'm much more concerned that they might have ITP, and patients' liver disease can also have ITP. In that setting, I check platelet autoantibodies and just overall a number of different autoimmune markers like ANA, and thyroperoxidase antibodies and things like that are known to be elevated in many ITP patients. And I make a clinical determination on the basis of the sort of best available autoimmune workup that I have. Most places do not do platelet autoantibody testing, so I recognize that we do this testing routinely. So we have experience with it, and when this is done well, it can be quite useful. But it does not have perfect sensitivity and specificity, as has already been alluded to.
Great. So there is one question I would like to direct to you, Dr. Hani or Dr. Hazza, if Dr. Hazza is still with us, that if you have used rituximab in a patient with initial response and the patient lost the response, would you reconsider using rituximab again in such a patient?
So Dr. Hazza, if you'd like to.
In those who relapse years after the initial therapy, we can use rituximab. It is not mentioned.
Kindly raise your voice. I think we cannot hear you clearly.
These guidelines. But I think if the patient has failed and then relapsed at least 1 year, more than 1 year from the initial course, or had a transient response, some response in the initial part to the rituximab, we can utilize. If other options are not,
Yeah, maybe I can add that if a patient has used rituximab and other agents like TPO receptor agonists have not been used, it may be more useful to use one of these agents rather than going back to rituximab. I mean, reusing rituximab these days would be really in a desperate situation.
Absolutely.
Yeah,
I think it is the balance between the risk and benefit of different therapeutic options. So, I mean, typically we would try to avoid an intense immune suppression with rituximab if we can use simpler different ideas.
Yeah, I agree with what's been said. And I agree with Dr. Haza. I think that if somebody got 4 years out of rituximab and they relapsed, it's perfectly reasonable to try it again and hope that they have a good response and are able to stay off a chronic pill or a chronic subcutaneous injection. But if somebody relapses relatively quickly, I don't bother trying rituximab again.
So because of the sake of the time, I will have one last question. Dr. Mansoor Al-Jabri, are you still with us?
Yes.
Yeah. So the question is, in a difficult situation, when it's difficult to diagnose ITP, what type of test you would use, and would you use the antibody test like a MAPA test in which situation?
I did not hear the question, actually. Maybe I have interruption in internet. Can you repeat it, please?
So
Can you repeat
in a
the question,
difficult
please?
situation, when the diagnosis is not clear in an ITP patient, when would you use, the MAPA test like antibody-based testing?
Yeah. Yeah, actually, and I've received some questions regarding the gold standard
Yes.
test for ITP. Actually, there is no test. There is gold standard approach for ITP. They have MIBA assay. MIBA assay we try.
The voice is not actually, it is cutting a lot. I'm not sure people can hear to Dr. Mansoor Al-Jabri, but I can't really hear him. Dr. Hani, can you hear him?
I cannot hear him.
Yeah, I think we lost him. Anyway, I think there is some problem with the system, and I had in between, I lost the connection as well, but regained. So in the end, I would like to thank all our worthy speakers for excellent presentations, as well as answering all the questions. And also, I would like to thank our sponsor today, SUPI, for sponsoring this webinar. And I would like to remind our viewers regarding the actually, I need to have the share screen because I think I'm not. Can you please show the next slide regarding the SSBD? Yes, yeah. So I would like to remind all our participants to attend 7th reception and perspective by the SSBD on 4th of December, which is Friday, 8 p.m. to 11 p.m. And during this webinar, some of the important abstracts presented at the ASH will be reviewed. I think it is going to be an excellent activity, and it has been a great activity in the past. So in the end, thank you very much. Thank you very much, and have a very good evening.
Thanks very much.
Thank you very much, and sorry for interruption.
That's okay. And that connection can be interrupted. This is technology, great benefit, but some problems as well.
It was a pleasure.
Can you stay with me for 1 minute, if I may?
Yes,
please.
I just have a question. I have a patient who is going for a spine surgery. He has chronic liver disease. His platelets is in the 60s. And we wanted to target a platelet count of 100. We don't have a thrombocard.
Yeah, so I would direct you to, so we actually published a study using riplastim end plate to raise the platelet count in patients in preparation for a procedure. What surgery did you say they were going to get?
Spine, vertebral spine.
I'm sorry.
Spine surgery. Yeah. Spine surgery.
Oh, spine surgery. Yeah, yeah. So it's published in the British Journal of Hematology. I'm the first author. Basically, a protocol that if you take basically if you give 3 micrograms per kilogram of end plate once weekly, you'll get to above 100,000 within 1 dose in about 3/4 of patients, and within 2 doses in over 90% of patients. So you can easily get them to where they need to go. And there's really not much of a concern about rebound thrombocytopenia. And because the end plate effect lasts for about a week after the last dose, you can time it to make sure that their platelet count stays for several days post-operatively, which the surgeons all want. So that's something that we do, we've had very good success with that in patients with chronic liver disease.
Would you worry about the risk of thrombosis post-op or any special precautions, mechanical or chemical thromboprophylaxis?
Yeah, in our trial, or not, excuse me, it wasn't a trial. In our study, we did not see really untoward rates of post-surgical thrombosis with this approach. I would, since the patient's platelet count is going to be normal, I would use, heparin-based thromboprophylaxis post-op as otherwise indicated for major spine surgery. I would not withhold that, and I would expect they would be unlikely to have a thrombotic complication.
Great, thank you very much. Thank you.
My pleasure. Yeah.
Thank you very much again, and I would like to apologize if we could not ask some of the questions, because there were some other questions as well, some of them interesting, but for the sake of time, we really have to close because we are maybe almost 10 minutes over time. Thank you very much for your attention, and thank you very much again for all the speakers and the sponsors.
Thank you all.
Thank you, everyone. Bye-bye.